Welcome to everybody. I'm Paolo Pelosi and I'm head of the Anesthesia and Critical Care Unit at the San Martino Policlinical Hospital in Genoa. Today my talk will focus on gut microbiome in stroke with possible therapeutic implication. No conflict of interest related to this specific talk. This slide shows the mortality in severe brain injury patient. And as you can see, patients with ischemic stroke or hemorrhagic strokes are characterized by very high mortality, up to 80%. So hospital mortality ranges from 40 to 80% in this group of patients. We also showed that patients with brain injury, and particularly patients with hemorrhagic or ischemic stroke, have a higher probability to develop respiratory complication, cardiovascular complication, and in some way also some amount of acute kidney injury. So peripheral organ dysfunction is also associated with worse clinical outcome in brain injury patients, and particularly in patients after hemorrhagic or ischemic stroke. We developed, together with our Spanish colleagues and Dr. Teixeira, a score in order to predict the severity of the injury and the likelihood of mortality. We found that the most important factors were the presence of hemorrhagic or ischemic stroke, much more important than the brain trauma, the age, older than 75 years, the overall severity of the patient in terms of clinical point, and the development of this fulcrum organ within 48 hours after the stroke. And as you can see here, we found a progressive increase in mortality, a progressive increase in the score. So more likely patients are developing dysfunction of different organs apart from the brain, higher is the probability to die or to have worse clinical outcome of these patients. We also investigated possible relationship between brain injury and peripheral organ damage. As you can see here in the first, second, and the third histological models, you can see that brain injury developed here by increased intracranial pressure, by a balloon positioned in the chiasma, and with good oxygenation. We found after 4 hours major infiltration of neutrophils and damage in the liver, in the heart, in the kidney. And you can see also in the fourth panel in gray that the inflammation score was higher, not only for the lung, but also for the heart in the left ventricle and the conductive system of the ventricle, as well as for the right ventricle, the liver, and the kidney. We found the same in terms of edema, that was higher in the peripheral organs, and necrosis. So, brain injury triggered peripheral organ damage. Which are the links between immunomodulation after stroke and peripheral organ damage? As you can see here, the vagus is one of the major links from the brain to the periphery, and especially on the activity of the macrophages. This is related to the activity of the acetylcholine, and the activity of the vagus is associated with a reduction in inflammation, and the other side, the inflammation reports signal to the brain in order to modulate the general response. Other factors are related to the ACT and glucocorticosteroids activation, as well as adrenergic activities like dopamine, which can have higher or lower activity on the inflammatory system according to the activities of D2 or beta receptor, as well as adrenaline or noradrenaline, again on beta receptor, a reduction in inflammation, and alpha receptor, an increase in inflammation, as well as different activities of the alpha-2 agonist related to the noradrenaline, which can be associated with a reduction in the inflammation process, especially when these receptors are activated by the use, for example, of external drug like dexmedetomidine. We also modeled and found in different experimental studies summarized in this paper possible activities from the brain to peripheral organ of different drugs. For example, dopamine activates the DRD1 receptor and the DRD2 receptor, which an alteration in the neural plasticity. Haloperidol may inhibit the DRD2 receptor, with in some cases an neuronal survival due to a probably increased DRD1 receptor, or sometimes a neural apoptosis with neurotoxicity. Dexmedetomidine, which stimulates after-2 receptor with increased neuroprotection and a reduction in apoptosis, as well as afferent vagus, which through the acetylcholine receptor may activate biological system which are associated with a reduction in the inflammatory response. There are also systemic effects with activators of catecholamines, which may be associated with activation of beta-2 receptor with a reduction in the inflammatory mediators, as well as an increase in anti-inflammatory mediators like interleukin-10. No clear activity on alpha-2 receptor, as we discussed before, or an increase in the activity of D2 receptor with an increase in the anti-inflammatory response and decrease in inflammatory response, or activation in the acetylcholine, which is again associated with less inflammatory response. On the other side, the activation of HPA axis with modification in the amount of glucocorticosteroids, which are associated with reduction in inflammation and activation in anti-inflammatory mediators, as well as the afferent vagus through the alpha-7 acetylcholine receptor, which are again associated with a reduction in the inflammation, as well as other activated systems like the DAMP. This is a combination of factors, and we clearly show that vagocholinergic reflex and sympathetic reflex then can have different effects on alpha-7 acetylcholine receptor, which reduces the inflammation, but on the other side, reduce the alveolar macrophage phagocytic capability. On the other side, sympathetic reflex, which may be associated with damage-associated molecular patterns, D2 and alpha receptor with an increase in inflammation, and the other side, activation of the ACT pathway with glucocorticosteroid, alpha-2 agonist and beta agonist with a reduction in the inflammation. And also alteration directly of the systemic inflammation, which may have an effect of the lung or gut cell inflammation with a reduction or activation of the lung injury or gut injury. So there is a balance between vagal and sympathetic reflex in this inflammatory and the anti-inflammatory response, which may have a major effect on peripheral organs and mainly on the lung and on the gut. In this setting, the intestinal microbiota and dysbiosis is very important, and dysbiosis is defined as a microbial imbalance in composition and function of the microbiota. And the intestinal microbiota are critical for health with changes associated with diverse human diseases, and research suggests that altered intestinal microbiota can profoundly affect brain function. The normal composition of gut microbiota is composed by different microorganisms, which may change from early age to older age, and related to dysbiosis with infection, inflammation, diet, xenobiotics, and genetics may affect dysbiosis. There are different data suggesting that germ-free mice compared to conventionally housed mice may have different effects on neural changes. For example, germ-free mouse may be associated with changes in myelinization, neurotransmitter and synaptic plasticity, and microglial pathophysiology. On the other side, neurogenesis, dendritic growth, and alteration in blood-brain barrier. So alteration in the microbiota may have an effect on the brain directly. Also, diet has a major important role. So high bicarbonate or high fat diet or high protein diet may have different effects. High carbonate diet may have an increase in high fermenting power species and decreases in bacteroides. The high-fat diet may be associated with increased species with bile-tolerant species, while the high-protein diet may have different effects on bacilli and lactobacilli. So, different type of diet may have a different effect on microbiota. There are different bottom-up and top-down signaling in stroke, and as you can see here, from the gut to the stroke to the brain, there are effects from the vagus, from the neurotransmitter and neuropeptides like serotonin, CVA, catecholamines, and others, immune and inflammatory response with native and adaptive responses, with gut barrier integrity through the alteration in the tight junction occluding in desmosome. On the other side, the top-down from the brain to the gut, through again neurotransmitter and neuropeptides like norepinephrine, epinephrine, dopamine, and serotonin. The so-called stress response fight or flight, related to the cortisol and corticosteroids activity, the mucus secretion in the global cells, and peristaltic nutrient absorption and changes in permeability. So after stroke, up to 50% of our patients develop the GI complication with dysphagia, gastrointestinal hemorrhage, and intestinal paralysis. In this slide is shown that the fact that the gut barrier, that in normal condition is directly related with lymphocyte T regulatory cells, which are associated with a decrease in inflammatory response from the gut or directly to the brain, and the plasma cell, which modulate the activity of GGA and anti-inflammatory system. When we have an alteration in the gut, these mechanisms are altered, so all these altered biomolecular mechanisms may be associated with alteration in the brain. So intestinal dysbiosis and mucosal damage may persist up to 12 months after acute ischemic stroke, and opportunistics can be changed to commensal pathogen when we have stroke. There are different clinical implications as shown here, so different organs may be altered, and you can see here that there are several gastrointestinal complications after stroke with intestinal hemorrhage, paralysis, and bowel incontinence and inflammation. So risk factors for clinical implication of intestinal dysbiosis in stroke are age, hypertension, obesity, diabetes, and vascular dysfunction. Gut microbiota may be associated with cardiac dysfunction as with an activation of TMAO, as shown here. So we have a link between gut dysbiosis, the brain, or gut dysbiosis, and directly cardiac dysfunction. And here is shown the activation of different brain areas during stroke may be related to specific cardiovascular complications. As you can see here, from frontal or insular or parietal or basal or insular and other areas of the brain are related to specific cardiac alteration, from arrhythmias to myocardial infarction. So which are therapeutic frontiers? We can have used probiotics and prebiotics with some pro and con, the diet, the possible activity of antibiotics, the environment, which is not very clear, and fecal transplant. All of them has not been clearly shown to have any effect in terms of therapeutic regimen. The ketogenic diet has been suggested with low carbohydrate and high fat diet with metabolic ketosis with reduced inflammation. So more use of lactate, fatty acid, and acetylcoenzyme A. This is associated with activation of factors which produce lower oxygen reactor species and increased adenosine, but also this has not been clearly shown. So to conclude, the microbiota gut-brain axis is a central regulator of the immune system after acute ischemic stroke with a potential lower indeterminate outcome. Brain-gut and gut-brain signaling pathways involve bidirectional communication between hypothalamic, pituitary, adrenal axis, the autonomic nervous system, the enteric nervous system, and the immune cell of the gut. Risk factors for acute ischemic stroke and gut microbiome composition are influenced by diabetes, hypertension, hyperlipidemia, obesity, and vascular dysfunction. The systemic inflammatory response after acute ischemic stroke may lead the liver, renal, respiratory, gastrointestinal, and cardiovascular impairment, including multiple organ dysfunction syndrome. Antibiotic treatment, diet, and probiotic have been shown conflicting results. Microbiota dysregulation after acute ischemic stroke remains a challenging target for potential new therapies. Thank you very much.